uh, not just my disease. So I would like to hear from you. What is the difference between the suffering and the disease? What do you think? Is there a difference or is it the same? I would like to hear from you. I hope all of you are able to follow English. Can everyone show me a thumbs up if you can follow English that I'm speaking? I'll wait for the thumbs up in the screen. I can see a few, at least 2, 3 people can understand English. Okay. Thank you, thank you. I can see only a few thumbs ups, but I'm not sure whether other people are. Thank you so much. So if there is any problem in between, please do let me know so that we can translate. I mean, I won't be able to translate, but we have someone who can translate to Hindi. I can see a response from Neha. Suffering affect the mental peace of person, and disease affects the body and physical disequilibrium. Thank you so much, Neha. That's a wonderful response. And sometimes. It will be only disease, but very often it can be suffering because of the disease also. Thank you so much for the response. So, how many of you have been to hospital for any illness, upper respiratory tract infection or stomach upset, food poisoning, fever? I hope most of us have been to, at least we'll self-medicate. Yeah, COVID-19, yes. I think everyone in this room will be having an experience with COVID-19. Thank you, Neha, for the response. Yes. So what happens when we have an acute illness? Usually either we self-medicate because we are in the healthcare mostly, but what happens otherwise? We go to hospital, we usually get cured. They will give you some medication. Within 2 weeks, you will all be back to your normal work routine, right? You will be able to go back to work, you will be cooking, you will be going to office, driving. Most of the things will be back to routine, right? With the medication and proper rest for maybe few days to weeks. But what happens to these kind of patients? Someone who just had a fall from a tree or a building or an accident, someone who was diagnosed with cancer with metastasis, or someone who had stroke. What happens to these kind of patients? What happens when they get this injury? They'll go to hospital, as I said, in the acutely ill patient. They'll get treated. They'll get surgery done, or radiotherapy or chemotherapy done, or for stroke they might be doing some correction if possible, if they are early in the time of treatment. Yes, so people may deny the stage of cancer. And any thoughts about will they come back to their home how they went out? Will they be coming back walking, and will they be going back to their work and office from the next day, like in COVID or in respiratory tract infection or diarrhea, whatever? Why do they need emotional support for adjustment? Why don't you give that emotional support to person with fever? What is the difference? When you had COVID, we all need some emotional support, right? But what is the difference? What happens when these patients are discharged from the hospital after the treatment? Are they coming back normal, and are they going to start working from next day onwards? Yes. Thank you so much. The patient or the person who got discharged, they'll need support. They are not going to be normal as they were, right? The person would have been going to work every day. Suddenly he had an accident. So, yes, Dr. Shalu is telling that for their mental stability, because they are depressed. Very correct answer, Jagrati. Their life will not be similar as before. They might have been the earning member of the family. They might have been the mother to few kids. They might have been a good homemaker, but their life is not going to be similar at all. after the infection or after the acute illness, maybe we will take a few weeks to recover. We'll be having some tiredness, but we know that we are going to be normal. I'm going to start working again in another few weeks. But these kind of patients, their life completely changes. They'll come back as a very different person. So Pankaj is telling it is not only suffering from the illness, but also from all the mental issues. Yes, so it is not about the disease. It is not about the CVA or cancer or the paraplegia, but patient needs some mental and emotional support because they are again not going to be back to normal. They can be near normal sometimes depending on the type of illness they have, but they are not going back to be normal as they went out. So very often they will be discharged telling that there is nothing more we can do. We did the surgery for your spine. Now you go back home and get your rehabilitation done. There is nothing more to be done from the hospital. And that is where we have to learn that there is always something that we can do. As you said very correctly, many of you said they need emotional support, they need mental support because they are not going to be back to their previous self. And it is not just the case of these three scenarios. This is about, we are talking about 10 million people. So your state will have a portion, your state will have a proportion of patients who has or who is going through serious health related suffering. It is not just about these three patients that I mentioned, but it is about millions of people in the country. And what happens when they go to a hospital? All of us have gone through that. The moment you are admitted in a hospital for a week, for 2 weeks, you're completely, your money is completely spent for hospital needs, right? The whole month's salary is gone to pay the bills. I mean, before getting into session, I was just having a casual chat with one of a patient who is my friend. So his mother got admitted in a hospital due to some viral infection and breathlessness, and it is just 5 days they could not pay the bill because it was 50,000. So they discharged her and brought her back to hospital, and they have no clue how to manage the oxygen concentrator at home, which costs 3,000 rupees per month. So that is how we all go through, including me. If I am told to get admitted in a hospital and I have to pay a bill 50,000 one fine day, I won't be able to plan out what happens. So many patients, because of the health related expenditure, they are becoming poor. They come below the poverty line. Is it very common in your place that you all work? It's interesting to hear. We see a lot of these things. Even though they are getting a treatment from a government hospital, they have to spend some money for the investigations, maybe a transport to the hospital, food for the caregiver, or they may be away from work, so the loss of pay will be another factor. So is it commonly seen in your place where people become poor because of health related expenditure? I'll wait for some responses. Yes, Dr. Shalu is telling yes, commonly. So when I first attended a session on palliative care, that's one takeaway point that I learned. The moment you start writing your medications or your investigations, you're actually taking away the next meal from that patient, right? They generally don't have the money. I have a known person last week was sharing an investigation was written for her son. They didn't have the money, so they sold the earrings that was on her and they did the investigation. That was the last piece of gold that they had. So it is very common everywhere. I can see in villages, basically, people are from poor background. And I think even if they are from a middle class family, they become poor after this. Very commonly, we see they have good house. When we go for home care, we think that they have money. But by the time they are finished with half of the treatment, they might have become poor on course of treatment. Yes. So many of you have the same experience that I have. Thank you for sharing. So we'll see what are the trajectories. How are we all going to die? Okay. Everyone belongs to this category. You can choose whichever way you want, but it is very difficult to get what we aim for. This is what everyone wants. We are on high functioning mode. You go to office, you are very healthy. One fine day, you meet with an accident or some immediate issue, and then you die. So people say, oh, he's very lucky or she's very lucky. He didn't have to go through anything. It was sudden death, someone having cardiac arrest when they are working or whatever. The problem is for the caregivers to cope with that, but the patient, we know that they are not going through any of the suffering. So that is one way of dying, but very low chance that we die this way, because it's 20% of patients or people in the earth will have a sudden death like this. So you have to be really fortunate to have that. What happens when you have a stroke or during COVID, not the COVID that we have right now, which might be a milder strain, but during COVID peak time, what we saw, a high functioning patient suddenly having a stroke or a COVID will deteriorate really fast. It is not a sudden death, but the time of suffering will be very short. They'll end up in sudden illness, and they become bedridden, and they die within a short period of time. This is another trajectory of cancer. You diagnose with cancer, suddenly your functionality reduces, but it is not abrupt. You go through a little bit of well-being, and then suddenly you deteriorate and die. That's one trajectory of dying. And this is very common. Advanced heart or lung disease. What happens? You can take an example of a patient with cardiac failure or a COPD. So they will have intermittent episode of breathlessness in between. They go to hospital they will be admitted in a hospital for a week. They will not be back to normal, but they will be near normal. Again, there will be a deterioration after a few weeks. Again, they'll have an episode of breathlessness or pneumonia. They'll be admitted. Again, their health status deteriorate a little bit. So gradually, over a period of time, with frequent exacerbation of illness, they will deteriorate. And what happens when people have illness like dementia or even old age? Their functional status will be low already. Already they are weak. They are not functioning as normal. Plus, they will have a gradual decline, and the prolonged period of, even in advanced heart disease and in dementia, they will have a prolonged period of illness. Their functional status will be very slowly deteriorating. So these are the 5 ways we all can die. And now we will see where palliative care fits into these trajectories. So this is the definition of palliative care. I'm not reading out the whole big definition, and I don't want you to by heart this also, but just focus on the red part of it. Palliative care is about improving the quality of life. I'm sure some of you might have already heard or already working in palliative care, but it is an approach that improves quality of life. And it is not just for the patient, but it is for their families. Why do we need to improve quality of life for families? Are they our patients? We are not treating them, right? So why do we need to include families there? Anyone? In between, you can unmute and talk, so there is some change in the voice. It is not just my voice that you are all listening, because they are also affected. Yes?
Because families are the closest one with who are with the patient, so they are equally affected.
Yes,
emotionally, mentally.
Yeah, totally agree, Jagriti. Thank you so much for unmuting. I wanted to hear to some other voice other than mine. Yeah, so it is not just for the patients. Anyone else? Do you agree that we need to treat the patients and their families also? Do we have the time and mind space to do all that? I mean, we hardly sit with the patient, right?
Yes, definitely we need to treat a family as well as patient, because family need more support than patient, I think.
True, very true. Thank you so much for your response, Surabhi. Yes, so we know that when someone falls ill in our family, like even for an acute illness, the moment you are having a fever, the whole balance in your family disrupts, right? Even it is for a day or a two, then you have all the questions: who is going to cook, who is going to drop children to school, who is going to take care of them, can I take rest, do I need to go to doctor? So every balance changes within a day or two. So we are talking about patients who are going to live with life limiting illnesses for their lifelong. So it is not just about one day, 1 week, 1 month. It is about the whole life. The whole family system is going to change. The role changes, The patient becomes bedridden. Sometimes you have to go for a job and earn for the children and the family. So all the family dynamics changes, including children in their family. Everything changes, right? And WHO says that palliative care is applicable early in the course of illness. So, do you agree to that, or people who are already working in palliative care or in the community? What is your usual experience? When do you get to see? When do you say a patient is for palliative care? At what point of their illness we say? Generally, that you see. So I'll share my experience in last 11 years. We usually, very commonly, now it is changing in our state, but most commonly we get very late referrals. When the patient, when they are exhausted with disease modifying treatment, if I take an example of a cancer patient, if all the chemotherapy is exhausted, they don't want to talk about their illness to the patient and family. There is nothing more that they can offer. Then they say, "You don't have anything to do. Now you go to palliative care." That's one experience, but it is definitely changing. I am interested to know what is your experience in your state. I mean, it is different in different places, but at what point of time do you actually see patients in palliative care already? And if you see, what point of time do you see, or what point of time do you think you should call it as a palliative care patient? Anyone has experience in seeing patients in palliative care, or at least heard about, okay, this patient is referred for palliative care, and at what point you have seen these patients being referred?
Ma'am, during my course of graduation, we were taken to Haridwar Hospice Center. Their patients were admitted mostly of cancer for palliative care only. Uh, so they used to admit patient only when they knew that yes, prognosis is very poor and now we cannot treat the patient. All we have to do is the palliative care, that is we have to do the symptomatic treatments. So generally I think we also it's my personal opinion that I have also encountered cases that have been taken to palliative care very lately. No one does it in early course of illness.
Thank you for sharing, Jagriti. Too. So I have one question to Surabhi. Yes, when patient lost all hopes, I think palliative care play a very good role. I totally agree to that. And Neha is telling terminally ill cancer patients also come under palliative care. I agree to that also. So we were talking about quality of life, supporting family. So I mean, just a question to all of you. Do you think you need quality of life only when you are dying, or do you need quality of life all the time? Even you know that you are diagnosed with something major, you might live for weeks or months or years probably. So patient with stroke or paraplegia is going to live for years, maybe 10, 20, 30 years. If they are young, yes, definitely 30, 40 years with paraplegia. So do they need, and their family needs quality of life when this person is going to die? Do they need palliative care because they are not cancer patients? So that's the first question. The paraplegic patient or patient with stroke, do they need palliative care? Yes. So Jagriti has agreed, yes, they need palliative care. I would like to listen from all the participants, not just a few, or else I am happy to call out names. Yes, so a few people agree that these patients need palliative care. Yes, Richa is telling, yes, they need quality of care. But when? The quality of care, the quality of life is given only when you know that, oh my God, this patient is going to die. Let's improve their quality of life. Or do you need the improvement in quality of life as long as they live? Yes, Surabhi is telling we all need quality of life. So if you read what WHO says, that it is given in conjunction with the other treatments which is intended to prolong life. So if a patient is going through chemotherapy, even though it is a stage 1 breast cancer, which is completely curable, or with mastectomy and a few radiation, they might be completely back to their normal. But again, there is a time when they lose their quality of life. There is a time when they have symptoms like pain. They'll be confused what to do. Their family will be completely shattered hearing that this person has cancer. That is the time where we should start giving palliative care. So that is an example for cancer I told. Irrespective of the cancer is curable or incurable, whenever they have a serious health related suffering, we don't need to wait for someone to die so that you can go and give compassionate care. Okay, now you are dying, I'm happy to give you compassionate care. No, they need the support whenever they diagnose with any life limiting illness. As a person with paraplegia or stroke, when they get discharged from the hospital, when they are at home, they don't know what to do with their life. They don't know how to move, how to change the clothes, how to shift the position. They don't know anything, but they are not dying. They are not at all dying anytime soon. So, what they need is quality of life. What they need is the support for them and their family members. So, just a few important points in history of palliative care. Who started it? It is Dame Cicely Saunders. Cicely Saunders was a nurse who was working with war refugees and soldiers, where she understood that just giving medications may not work in treating someone's pain. So she decided to become a doctor and started prescribing pain medications. Later on, she became a social worker also, so that she can address. You mentioned in the beginning that these people need emotional support. So she wanted to give emotional support also. So she is the one who started the hospice movement, which started in UK, and she built a hospice in London, which is called Saint Christopher Hospice. It is the first ever palliative care movement in the world. So that's from where the whole concept started. So everything we are discussing now, you have so many people from your state attending the program so that we can reach people who are in need. But what happens in the country, I told we are having 10 million people who needs this care, but only less than 4% of people in India has access to pain medications. I'm sure you might have, in your state, you may have difficulties in, I don't know how many pain specialists are there. When I say pain specialists, it is not just anesthetists giving blocks, but anyone who understands pain, anyone who understands medications, how to prescribe, when to give, and anyone who has access to these medications. That will be very, very less. So in total, in our country, it is less than 4% that we are giving pain control to patients who are in need. So this is story of Mr. A. I want you to listen to his story so that I'll ask a few questions about him. So this person was diagnosed with a curable cancer in the oral cavity. He went to take treatment from the hospital, and they told, okay, you have to go through biopsy and later on radiation and everything, and a surgery probably to remove the lesion. He really got scared. He didn't take any treatment. He went back home because for going for surgery, radiotherapy, and everything, he needs to take leave from his daily wage work. So he told, I don't have the time to, I need money to for my family. So I need to go back for work. So let me do it later. We all do it, right? We know that almost majority of the cancers, they start treatment very late, thinking we keep postponing our health related needs. So he didn't go back to the hospital. He really got scared. So he took some pain medications. He was okay for a few months. Later on, Mr. A developed severe pain, unable to eat, drink, or sleep. He went back to the hospital, but by that time, the cancer had progressed. And they told nothing more we can do because we offered treatment in the beginning. Now it is progressed. What we can do is like we can put in a tube so that you can eat and drink. You can have your medications. So he was given a rice tube through which he can feed himself, and he came back home. So he has his wife and 3 children at home, and he has an elderly mother at home. He was the only breadwinner at this place. So I'd like to hear from you. So we, when our team went there, we all asked all those history, what happened, when did you go to hospital, how did it start, etc. So the patient was sitting like this. And what do you think will be bothering him the most? What can be the issues that he might be going through, and why he must be sitting like this? I'll wait for some interactions. So we all will be silently watching Mr. A suffering, or will you be asking more or thinking what might be happening? Yeah, Dr. Shalu is telling that he is thinking firstly for his family, and Turbi is telling pain and tension for further treatment. Yes, yeah, patient can be hopeless. Yes, very, very true. Because of the NG tube, he might feel his physical appearance is not good, and people may not want to go out, especially when they have a wound or when they have an NG tube. Anything else? Yeah, he might be thinking why it happened to me. Yes, financial issues. How am I able to manage for the treatment? Yes, Pankaj, fear of death. So Deepak is telling secondary about family. So initially there will be worry, and then how am I going to take care of my family? Thank you so much for the wonderful responses. You have covered whatever I have written in the next slide. So the first worry was, will I be able to pay my medical bills? Although they're getting treated from a government hospital and they get treatment for free, as I mentioned before, we have to pay a lot of expenses from our own pocket, right? We have to take a vehicle. He cannot be going for job, food, medicines. Some investigations have to be done from outside. So medical bills is a problem even when they are getting treated from a government hospital. And as you rightly mentioned, the next thought process generally all the patients will go through is that how will I provide for my family? He was the only earning member, and how am I going to provide? And it is not just the case of a daily wage worker. Even we take our own examples. Maybe we are the only working members in your family. We'll be going through the same thing, right? Even if both of us are working in a family, we think, okay, one person's salary is not there. How am I going to manage everything at home? So it is not just about poverty as such, but it is common everywhere. And then he doesn't want to eat or talk. It can be due to pain, it can be due to someone, like told, physical appearance is a big thing. I don't want to talk, I don't want to see anyone. And there might be usually a foul smelling ulcer probably in his mouth, so he doesn't want to open his mouth. And then he told, so pain came, what fourth problem? So we don't need to jump into pain all the time. Sometimes it will be the last concern, but they will be in terrible pain. But apart from the physical things, his mental issues were popping out first in his head before he spoke about the pain. There is too much pain. And because of the pain, he has not slept for many weeks to months. He is unable to sleep. He's screaming in pain at night. He's not letting others to sleep because he thinks that if they sleep, there is no one to listen to my pain. Night, what if I die in sleep? And as someone very rightly said, this is very commonly asked by patients, am I going to die now? Because I was all right till some time back. Now I have a tube. Someone has to feed through my tube, and I am in severe pain. I'm not able to eat or sleep. So it's really that it might be possible that I'm going to die now. So it is not about pain in different dimensions. So here we are not talking about the pain that he has in the oral cavity, which might be radiating to his head, but here we are talking about his psychological pain. Okay, why? How am I going to manage? What is going to happen to me? And socio-economic, like you might have seen patients with especially cancer, which is actually shown outside with lesions. I mean, they don't prefer to go out. They don't entertain visitors sometimes. Sometimes people don't want to visit them because they look weird. Even the family members tend to isolate them due to stigma, fear of spread, or fear of they don't want the foul smelling ulcer somewhere shown in the family. Sometimes they are given separate plates and spoons and glasses so that cancer is not spread. I mean, that is also common, not very rare. And economic issues, as you told, who is going to take care of my expenses and financial issues? And someone pointed out about why me question. This always happens, right? Even with a small illness, we ask that question to ourselves. Oh my God, why this is happening to me? I should have been much better. I should have cured of this cough a little earlier. Why I'm sneezing every day? So even with small issues in life, we ask that question, why it is happening to me? So whenever there is a life limiting illness, there is always a question on, is God punishing me, or I didn't do anything bad in the past. Sometimes patients used to share that, oh, I used to be very harsh to my wife and my children, and I used to beat them up. Maybe this is a punishment because I did something in the past. Maybe this is what I have to go through. This is my karma. So all these thoughts will come, and that will contribute to their total pain. A simple example would be, if we have a headache when you are at home, what happens? Your mom or dad or spouse or someone, if they are giving nice hot tea and giving some massage, and then you can switch off the light and sleep, your headache will be gone maybe in an hour. You get a good rest. Next day morning, you are fresh, right? Suppose you are far away from your home, you are in a hostel, you are there. Tomorrow there is an exam, you have to submit something, and you are completely away from your family. Then the headache will feel different. It might be the same headache. There is no one to take care of you, no one to give you something, no one to give you a head massage. You can't take rest. The headache will feel very different. The same pain behaves in a very different way. So, all these contribute to the total pain. So, as I mentioned in the beginning, the suffering and the illness. The illness related suffering is much, much more than a physical distress. It contributes, it is exaggerated by your psychological, socio-economic, and spiritual distress. So, even if you give your medication, you may not be treating the pain unless you treat the total pain. Your medications will take care of only one part of it, only the one column on the left top, the physical part of it. Unless you take care of the other three parts, you cannot cure someone's pain. And what we see every day in your clinical work, when you go to community, when you see patients, in the hospital, whatever we see is only the tip of the iceberg. There will be a lot of suffering that they will be going through, which is not seen above the top. You have to really wait, explore, understand more so that you can reach to the bottom. So, unless you reach the bottom, what happens? You're not anticipating the iceberg under the water. You keep treating the top portion, you will not reach anywhere. So, we have to go much, much, much deeper so that you will understand why this patient's pain is not being treated. So, as you mentioned in the chat in the beginning, where people are sent to hospice when they are nearing death, that is a very old concept. Initially, when the palliative care movement was started, it was like, okay, there is nothing more we can do. Now you go and get palliative care and you die in a hospice. That is a very, very old concept. Now we talk about integrating palliative care. As you all have agreed, we all need quality of life, no matter what illness we have, right? It is not when I am going to die, someone of you is coming and telling me, okay, now I can give palliative care. I need that care the moment I am going through the illness related suffering. The moment I am diagnosed with cancer or when I have a stroke, that is when my family needs your support. That is when I need your support. So it has to be integrated from the beginning along with the treatment. So I will be getting chemotherapy and radiotherapy, but I'll be getting palliative care also. So it has to go hand in hand with the disease modifying or curative treatment. And if you look at the screen, you can see a little bit of pyramid extending after death. So the straight line is death. You can see on the screen, and you can see there is a little triangle extending beyond death. That is called a bereavement support. Even if the patient passes away, as you mentioned in the beginning, family needs support. So many people agreed, oh, family will be going through a lot, family also needs support. So even when the patient dies, the family still needs support for some more time. Some families will cope better. Some families will take a longer time. Some people suicide. So we don't know how they are going to cope with the absence of the patient. So that is where we continue our support in the form of family bereavement. So just to help to cope with the person's absence from their life. So this is a picture which describes what palliative care is and what palliative care is not. So as we mentioned in the beginning, a dying patient, everyone sees it. So you can see the plant on the left side where the plant is going to die. There is no support. It is dry. There is no flower. The leaves are dry, and it looks it is going to be dead soon. But what palliative care is? Palliative care, you can see that the root is well supported within the community. So you all are working in the community, right? You are all CHOs. So you are the support that is to be given to this particular plant, which is the patient. So unless you give that much support from the community, the plant cannot survive. Whatever we do from a hospital setting, whatever medications I give, the community support is what determines the strength, right? And then we can give pain relief and symptom management. Plus, I told about psychosocial and spiritual issues, and we should have good communication with the patient. I have to tell Mr. A, okay, what is happening to you? He might be asking me, am I going to die, doctor? Who is going to take care of my kids? How is my mother going to take it? So I have to be empathetic. I have to understand what he is going through and communicate it in an empathetic way. And that is how we help the plant to live as long as it can. The plant is not going to live forever, right? But it can bloom a little bit before it dies. So that is where how palliative care can be described. So left side is what people think palliative care is. So I'm not sure when you start working in palliative care, everyone will ask you, oh, you are going to treat dying patients. Why do they need care? Or you're going to work in a place where a lot of death happens. So it is not about death. It is about giving life till they are dying, right? We are living till the moment we die. Unless you die, people don't call you dead, right? Till then, you need all this kind of support, and you need to give that to your patients also. That is the difference between the myth and the reality of palliative care. And another myth is that it's very common that palliative care is only for people dying of cancer, which is completely wrong. Many people can benefit from palliative care. It is not just about patients, but it is also for patients and their families. And it is not everywhere. So I have an experience when one lady was sitting outside the OP. I saw her crying even before coming into the room. So as soon as she got in, I asked, why you are crying? So she told, I know why people are being referred here. I have a neighbor of mine who was referred to palliative care. She died in a week. So the doctor has lost hope for me, so I'm going to die. So that is a myth. It is not about giving up. As I said, we are actually nurturing the plant. The plant can start blooming. It can give good fragrance and flowers till the time it is living. It is not just about giving up. And we are not hastening death. Okay, you are here, now we give something so that you can die fast. That is very, very wrong. That never happens. It is not about hastening death. It is about giving good comfort care, no matter what your diagnosis is, no matter whether you have cancer, stroke, or dementia, or whatever. If you are having a serious health related suffering, you have a right to get palliative care. And these are certain other myths that very commonly doctors say, oh, you have cancer, you are bound to have some pain. What do you think otherwise? So pain is a part of serious illness, but you don't have to suffer pain. You can get treated for pain. It doesn't mean that you have some illness, so you have to go through pain. Pain is something which is completely treatable. And some patients, when they are given morphine, or some doctors say it is administered to hasten death, that is a very, very wrong idea about palliative care or pain management. It is an analgesic given for cancer pain management. So we were talking about who should get palliative care. It is not just about cancer, but it is also for patients with COPDs, end-stage cardiovascular disease, end-stage neurological illness. All these patients need palliative care. And it is not, it is very, very important. It is not dependent on the diagnosis. So we can't say, okay, now you have cancer, you are privileged, now you get palliative care. That will not happen. If you have a serious health-related suffering, we need to improve their quality of life. So diagnosis is not the criteria for giving palliative care. Now we were all talking about patients dying, cancer, elderly, dementia. What about children? So it is also for, generally when we talk about palliative care, we imagine in our head a very elderly person unable to move, completely bedridden at home, lot of poverty. That is not just the case all the time. Children are born, some of the children are born with anomalies, children with cancer. So they are all going to live through the life limiting illness through their entire life, right? So it is not just age dependent, it is also for children who need care. So again, you're all CHOs, I'm sure you're all having a lot of experience in the community, and I don't need to tell you how it is different when you go to a patient's house. We see the patient in a hospital, it is very different from what happens in their house. And it is very important to deliver care at their doorstep. I don't need to tell this group what is the importance of delivering care in a home based or a community based setting. And I'm sure all of you will be going through these kind of terrains every day. And we know how difficult it is for a patient to. I mean, I find it very difficult to climb all this and reach somewhere. So, how difficult it would be for a patient who has an illness like Mr. A. Mr. A was told to come back after a month for a review. How is he supposed to climb all this terrain and reach a hospital? Who is going to take him to hospital? His children, wife, and an elderly mother. So it is very difficult for these kind of patients to reach to a healthcare system where they don't have anything to do. They are just going there for a review. The doctor might tell, okay, come after 2 months. Repeat the same. So for that, they have to invest a lot. That is where the importance of home-based care. And home-based care, the family also plays a major role. It is not just us going. So you all go for home care, I guess, at least in the community you go. You go once in a month, you go maybe once in 2 weeks. So what about the other days? Other 29 days, the patient is in need. The patient needs medication, the patient needs something to do with the constipation, shifting, lifting, eyes, nails care. You are not going to go there every day to do all this, right? There you have to train their family members so that they can do it at home. So family plays a major role. Training the family members plays a major role in palliative care. And when I told about Mr. A, I mentioned that Mr. A had 3 children. So what happens to the children generally? I'd like to hear from you. What happens when there is a person diagnosed with any serious illness? In your setting, what happens to the children? Children, do they take care of their parents, or are they involved in caregiving, or do they go for work outside so that the family can survive? What happens? What have you seen? I'll wait for some chats or some response. Just interesting to know what happens to children in your setting. So Sujata has given a response, education affected. Anyone else? Have you seen something? Mentally affected, very correct. And do we speak to them about Mr. A's illness or any father or mother who has cancer or
Ma'am,
anything else? Yes, Jagrati, tell me.
we don't talk about illness to them, but the thing is, children understand it when they see their parents or any family member sufferings. They understand, and they also can feel that thing that something is going on. So mentally also they are affected, and also their education, every thing that is related to finance is affected. And children even stop. Sometimes it's been seen that children even stop playing or talking to people.
Very true. When we don't talk to children about what's happening, but as you said, they will understand, but we don't know what manner they understand unless you talk to them. So we have had experience in the past when the father passed away, the child thought, okay, when the father used to beat me up in the past, I used to think, oh my God, this is better that he died. So is it because that my father died? So they won't ask, they won't share all this to the family member. And what happens when the children ask the family, Amma, what is happening to my dad? They say, no, everything will be all right. He's sick, he'll be all right. Or you should not talk about like that. Sometimes they ask, is he dying? So then they generally what happens in homes? Oh no, you can't say like that. They feel it. Sometimes many children, they feel it's their mistake. I could have done something. I could have prayed harder. Or, I mean, I don't understand anything what is happening. They don't love me anymore. And what happens when there is another child in the family who is sick? All the attention, the toys and the food and the clothes, everything will go to the illness related child. Or if the father or mother is ill, they have to take care of their parents, and they become an adult when they are still a child. And but we consider them as children and we don't talk to them. So they go through a lot of mental issues, and many of them drop out of the school because there is no one to. I mean, whether you have to send your child to school or whether you want to buy medication. And if the mother or if Mr. A's wife has to go for work, the children has to take care of the father. Someone has to feed. Someone has to take him or give a support to go to the toilet. So all this can happen. As Kavita has mentioned, negligence, that is also there because it is not someone is actually doing it. Everyone is focusing on the patient, right? We know that we are going to lose the patient. Their children's education come in the last. They are not bothered, or we don't have time or mind space to do that. It's not no one's fault. So it is our duty to listen to them. We don't have to tell that, okay, your father has stage 4 cancer, now he's going to die. We don't have to tell that. But it is important to ask them questions, give them a space to talk to you. Let them open up what do they think about it. Let them ask questions so that there is someone to give them a right impression about what is going to happen or what is happening in the family. Thank you so much for the interaction. So this is another story of a lady who was diagnosed with advanced breast cancer, and it was spread to lungs. She was very breathless and a huge wound on her breast. So she was taking treatment from a cancer center. They could not afford the pain medications there, although she was getting good pain relief from there, but they had to pay for the medication. So they came to us and they needed home based care because the lady became so breathless because of the lung metastasis. So what we saw or felt at that home, I don't know how many of you have experienced. Sometimes when there is a patient with a cancer wound, you can smell the wound right from the door. Even before they open the door, you know that there is such a foul smelling wound from the house. So we could smell there is a wound before we entered the home, and we could hear someone screaming because the pain medications were over. And when we asked, these were the physical issues. She had a huge wound, a fungating wound with maggots crawling over the wound. And you know that when there is a breast cancer, there can be a lymphedema on the same arm because of the lymphatic obstruction that can happen. There was a huge arm which is compressing a lot of lymph nodes, which is compressing her trachea, and she was severely breathless. She had a lot of nausea, vomiting, and she was not sleeping due to breathlessness. So she was sitting all the time because she is unable to breathe when she lies down. And we asked, so this is one important question that you need to start practicing. What is bothering you the most? As in Mr. A's case, it was not the pain, it was about the finances and children what was bothering him the most. So in this case, her problem was two daughters. And she said, after the illness, the husband rarely comes near me because maybe I'm ugly, I'm foul smelling. My husband started hating me, is what she told us. And the doctor told that no need to come for treatment. They told, okay, now onwards, you go to this NGO, register there, they will take care of you. No need to come here. So these were the issues that she is going through. Then she told, when I am ill, everyone will come to visit me and I am stinking. I mean, she can see it on others' faces that she is foul smelling. Their expression changes, they can't tolerate the smell. So I feel I'm a burden for my daughters and my husband and whoever is coming to visit me. And doctor, tell me, why should I be even alive? I can't move, I can't sleep, I'm breathless, I'm vomiting all the time, and I'm stinking, and I have worms on my body. Why should I even live like this? So these are the questions that she asked. And as we mentioned, why this is happening, why God is punishing me like this, why can't He just take me away from this world? I'm sure many of you might have heard the same questions and concerns from patients. So here again, as we discussed, it is not just the physical pain, but it is a total suffering that she is going through. And what we did, we arranged a home visit for her so that she doesn't have to travel to the hospital. And what happens if she is unable to come, or if we are unable to go there, we can treat by relatives report. Sometimes we ask the husband, okay, how was the pain? Did she sleep well, etc. And she cannot go to hospital. She's so heavy, the arms are so heavy, the roads are really bad. So we arranged a home visit for her. So as I mentioned, the terrains will be really hard to go, and we go as a team of doctor, nurse, if available, a social worker, and the driver who will be trained in palliative care, and we carry all the medications which is needed with necessary documentation and some things which are needed for doing minor procedures at home. Sorry, I'll just. So what we did for her, she was on severe pain because she was out of morphine from the previous hospital. We restarted her on morphine and her pain was 10 out of 10. So you will be hearing more about the pain scales later, but her pain was very severe. And with the medication, her breathlessness reduced and she was able to sleep. And we removed all the maggots, and the wound care was taught to the daughters. Two daughters were there. One was going to college and one just finished, and she's not going anywhere. So we taught her how to take care of her mom's wound, how to make dressings and everything, which again you will have a session on the same. One child, she was going to school, 12th or first year of degree. So we supported her education so that she can continue going. And then we had a separate conversation with the husband, because the wife told, what did she tell? The husband is not coming to me because I am very ugly or foul smelling. So we just wanted to know what is happening in their family. And what the husband shared is that when he cannot bear, it is not that he hates her, he feel helpless. He feel helpless when she cries. He did not do what can be done from his side, and he used to cry on his own in another room. So it is out of love, out of care, that he felt like a failure. I did not do enough for my wife. If I had the money, I would have done something better. So the husband was feeling so guilty that he could not do anything more. So it is not that the husband was hating the wife, it is about more of a love and concern. So it is very important to talk to each member of the family to understand what they are going through. We'll get a different picture when we start talking to each member of the family. And then we talked about advanced care planning and death. It is a very difficult area. Again, you will have another session on that, but it is very important to prepare the patient and the family when we know that it is advanced, the prognosis is bad, it is very important to do an advanced care planning and talk. Asking her, what if the breathlessness increases? You want to be at home, or do you want to be shifted to a hospital or a hospice? I mean, what do you want to do? So sometimes patients say, I want to be at my home no matter what. You give everything at home. Sometimes they say, no, I feel unsafe at home. Can you please admit me when I become so breathless? So it has to be planned in advance, not when the patient is breathless and dying. You can't ask, okay, what do you want now? You can't give the menu then and there. So it is important to give it much, much earlier so that she can think what she wants in life, whether she wants to talk to her doctor. So I had a patient who had a big oral ulcer, I mean, cancer wound, and whole of her throat was exposed. She couldn't talk, she couldn't eat. But she used to write notes on a notebook, including where the gas bills are kept. You have to do this on the 10th, you have to check the electricity bill. And she has even written, you have to tie your hair carefully before you go to school, dress properly. So everything was written on a book before she passed away. She knew that she is deteriorating and her daughter has to take care on her own. So she used to write everything on a book. She used to write on a paper. So I gave her a diary. Why don't you write it on this? So the daughter, so every minute details was written. So it is about preparing them for what is going to happen, giving them good symptom control and preparing them for the death. So with that, I'll end my presentation and I am happy to take any questions. If anyone is unable to follow English, just let us know. We can address your concerns in Hindi as much as possible. Uh, it will be good if, I mean, we have done with the didactics. It will be good if you can switch on your videos and be interactive, ask a few questions, or if you have any experience to share, if anything that you, in your own experience in the community, that will also be very nice to hear. Are there any questions or any comments? I can't see any questions or comments. So I'm assuming that you understood what we have been discussing. So thank you so much. And we'll be having another session on Wednesday. We request you all to keep your videos on whenever you are in the session. Otherwise, it will be just a didactic. We are looking for many interactive sessions in the coming days. So there are no more questions. Maybe we can wind up today's session and see you all for the next session. Thank you so much.